We thank Dr. Mo for being here. She is an associate professor at UMKC Medical School in Obstetrics and Gynecology. And she also practices at Truman, Children's Mercy, and St. Luke's hospitals. And she primarily, she enjoys delivering babies and serving women. So with that, Dr. Mo.
Okay. Great, thanks. So what I wanted to talk to you about today is some issues about maternal mortality. There's been a lot of press about it the last few years. In the rest of the world, the maternal morbidity rate, maternal mortality rate has fallen by 44% from 1990 to 2015 in low and middle income countries. But it's rising in the United States. So we're an anomaly amongst first world countries. And we are at the rock bottom of all the first world countries with our maternal mortality rate. And so what I want to try to do is to talk about this and some of the issues that are going on and some of the things that we think can be done to try to address this. So the first thing I want to do is have some definitions. There's a maternal mortality rate, and that is calculated per 100,000 live births. And it's from pregnancy through 6 weeks postpartum, 42 days. And then there are other levels which are being looked at in the state of Missouri. And so I want to talk about that. We have no data from the state of Kansas. I went online, tried to find stuff, and we're one of the states that does not report maternal mortality to the CDC. So we don't have any data. I'm sure that we're lower than Missouri rates, but probably not by very much, because just about everything else that happens, we're pretty close with maternal care to Missouri. And we've all heard of the first, second, and third trimester of pregnancy. And now the latest thing that we talk about is the fourth trimester of pregnancy. And so that's from birth until 6 weeks postpartum. And I'm assuming that most of you are fairly well educated. And if you've had children, you knew you were supposed to keep your 6-week postpartum visit, and you went in and got seen if you've had children. And what happens is that a lot of our patients don't know that there's any risk once they've had that baby. They think that everything's back to normal immediately, and it's not. It takes about 6 weeks for our bodies to go back to normal. And so there are lots of changes that are happening. And if patients aren't educated about it, they don't know what to look for. So we're trying to get more patients to come in for their 6-week postpartum visit. When I was in private practice in Johnson County, I had about a 90% show rate for my 6-week postpartum visits. Down at Truman, which cares for a lot of the Medicaid and indigent patients in Kansas City, Missouri, we have about a 25% show rate at the 6-week postpartum visit. And it's just, I'm not sure whether it's not seen as important, whether there are issues right now. Until this past month, the patients couldn't bring their babies back in. If you're lower socioeconomic status and you don't have a lot of family in town, finding somebody that you can trust to leave your 6-week-old baby with while you go in for an obstetric visit that you don't really see the significance for, that's a big barrier to care. So COVID really hurt us this last year with not being able to have mother-baby dyads come in. We finally got that changed just recently. So maternal mortality, and this is one of the slides that's helpful. The maternal mortality, and this is World Health Organization, is deaths occurring during pregnancy and up to 40 days postpartum that are related to pregnancy. So it doesn't count if you're in a motor vehicle accident. Then pregnancy-related mortality out to 1 year is what we're looking at, although not reported in the international statistics, are deaths during pregnancy and up to 1 year postpartum that are related to pregnancy. So we know that patients initially postpartum in Missouri tend not to use drugs, but they're more overdoses the further you get out. The patients got clean off their drugs for the pregnancy, then they don't understand that they're going to need a lower dose if they start using drugs again, so they have overdoses. Mental health issues, we now call it peripartum depression rather than postpartum depression. And we know that depression occurs from the very beginning of pregnancy all the way through a year postpartum. That's peripartum depression. But you see the maternal mortality, if you commit suicide after 42 days and it's postpartum depression, isn't going to be captured in the maternal mortality rate that the World Health Organization and big international bodies use. Does that make sense that there's a difference there? And then pregnancy-associated mortality out to 1 year are deaths during pregnancy up to 1 year postpartum. And this might include your other issues. And also going back to the pregnancy-related mortality, cardiomyopathy, where the heart muscle doesn't work, it becomes weak, frequently doesn't occur till after about 42 days postpartum. So that you'll find in slides that come up further along in my talk is one of those pregnancy-related mortalities that we see the problem later on. We don't see it early on. But the maternal mortality rate, we're still at the rock bottom of all of the industrialized countries. But we've gone from about 9 per 100,000 live births in the late 1990s up to 17 per 100,000 by 2016. So while it's gone up, it hasn't gone up a lot. If you look at low-income countries, there's a group that looked at Guatemala, a couple of counties, a couple areas in Pakistan, and they found in Guatemala, the maternal mortality rate is 97 per 100,000. And in Pakistan, it's 327 per 100,000. So it's much, much higher than what we have here. And the risk factors internationally are no maternal education, if it's your first pregnancy, if you've had more than 2 children, if you have an obstructed labor, so if the baby's not coming down through the pelvis, and a severe hemorrhage before delivery of greater than 1 liter, and hypertension. And actually, in the countries they looked at, Guatemala, Pakistan, they looked at Kenya also. If you saw a physician, if you delivered in a hospital and you had a C-section, you had a higher maternal mortality rate. But that's probably self-selecting, that these are patients that had more complications, so they had to go see a physician rather than delivering at home. And they had to come into the hospital because they had an obstructed labor. So we need to think about the pregnancy as a continuum, and preconception care is a really big idea. And I get so excited if a patient comes in and is thinking about planning a pregnancy. Only in the last 5 years have we had more than half of pregnancies in the United States are planned. And that's because we've got longer acting reversible contraception like Nexplanon that goes in the arm that's good for 3 years and it's over 99% effective, and we have more IUDs. So we've got better contraception. So this is the first time that the last 5 years that we've hit less than 50% of pregnancies are unintended. So it's really nice to have some preconception care, get the blood pressure under control, get the if somebody's got a medical issue, get it under control before. Then there's pregnancy, and then there's a 4th trimester or post-pregnancy. And maternal deaths About 31% occur during pregnancy, 17% around the time of delivery, and 52% are postpartum, which is up to a year. And I think that's part of what we don't understand quite as much. So I already talked about the decline in the maternal mortality rate by 44% between 1990 and 2015 in low and middle income countries. Thanks, Beth, for getting that working. And then this shows you in the United States from 1915 through 2017 that our mortality rate was decreasing. My dad's 100, and he was actually born in a hospital in Philadelphia because his mom had rheumatic fever, and my grandmother had been told not to have any children, and she ignored the doctors and had two. But she wound up delivering in a hospital, and her risk of dying in Philadelphia, it was one of the worst places to be, was about 980 per 100,000. So I'm really glad that both of them lived, and my dad's still alive, but I always think about that he delivered in the hospital rather than at home, but it was pretty risky for him to be anywhere in Philadelphia. But now since 1990, we have this increase in maternal mortality in the United States, and that's what we're trying to figure out, and that's what I really want to help you all understand. So part of this is better reporting. So until 2003, there wasn't a question on the death certificate about whether or not the patient had been pregnant in the last year. So we really had no idea. And we think that at least a third, if not a half, of the increase between 2003 and now in the maternal mortality rate is just better statistics. But there actually is a true increase in maternal mortality. So that only accounts for 50% of the increase. The other increase is true. So it's not quite as bad as the numbers make us think, but it's still bad because in the rest of the world, this is not happening. And so what are some of the issues? So this slide goes back, I hope everybody can see this. It goes back to 1915 and goes through 2014. And most of this data comes from the CDC. So there's always a 2 or 3 year lag time. This is the best numbers I could get. This slide set was made in 2020. So it's really hot off the press. And back in 1915, Black mothers were twice as likely to die as white mothers, but now it's up to about 3.5 times as likely to die as white mothers. And Hispanics are somewhere in between Blacks and whites, and Alaskans and Native Americans are up close to the Black mortality rate also. So we know that the Native Americans and Alaskans and the Black Americans are having the higher maternal mortality rate. And it's going to be multifactorial. So this looks at different race and ethnicities and different causes of pregnancy-related deaths between 2007 and 2016. So the first column on the left is all, and then there's whites, Blacks, Asians, let's see, the AI and AA is, I'm sorry, it's AI and AN is American Indian and Alaskan Native. And then there's Asians, Pacific Islanders, and they're Hispanics. So there are different things that cause the issues. So there's more severe bleeding with the last 3 columns. There's more infection in some groups than in other groups. There are more blood clots in some groups than in other groups. Amniotic fluid embolism, we never want to see, but unfortunately we see, and it happens usually at the time of delivery, and it's catastrophic. There's lots of things that happen, and the sort of purple is the weak heart muscle, that's the cardiomyopathy, and you see that more in the third column over the Blacks. and the American Indians and Alaskan Natives. And there's probably some genetic component to that, but it hasn't been completely teased out. We also have trends. We've got more obesity, we have more hypertension, and then increasing age at the time of pregnancy. And so we all know that we've got an obesity epidemic in the United States, and patients don't. Pardon?
What the last sentence you just said?
We have obesity, hypertension, and increasing age at the time of pregnancy. So we all know we have an obesity epidemic, and our patients who are obese don't get the drift that they're at any increased risk for complications. It's sort of amazing every day when I see patients and I tell them that they have an increased risk of infection, they have an increased risk of bleeding, they have an increased risk of preeclampsia because they're obese, and they look at me like I'm from Mars, okay? And hypertension is increasing, and you know, I have one patient recently who came in and she's got some chronic kidney disease. She's on 3 blood pressure medicines. So her blood pressure is under control with 3 blood pressure medicines. She wants another pregnancy. And I'm telling her, this is much risk for you for stroke and eclampsia and all sorts of complications. But she doesn't listen to me because she wants a pregnancy. And the kidney doctor said, well, better for you to have a pregnancy now than wait till later. And I'm like, no, time out is, when I've got her on 3 medicines, I have nowhere to go when she's pregnant, and she'll get more high blood pressure when she's pregnant. But what we advise patients and the will to reproduce are 2 different things. And then increasing age at the time of pregnancy, women are getting older when they have babies. And then everybody thinks that the movie stars can have babies in their 40s and have no problem. But we find that when in the women over 40, there's a much higher risk of complications and mortality. And it's really hard to get patients to understand that what the ladies do in Hollywood is different than the rest of us, okay? They can spend all day, every day being at the gym, working out, being slim and trim. That isn't reality for the rest of us. I already talked a little bit about the disparities. And then we know that amongst white Americans, the more schooling you have, the less your risk of maternal mortality. So this very first column here is folks who have had less than high school, and this dark blue are Caucasians or whites. And it doesn't make a lot of difference if you only got through high school or didn't get through high school. You have about the same pregnancy-related mortality. But if you go down to somebody who went to college, you've cut that by 2/3, okay? Which is sort of interesting. But if you're Black, why high school is even more risk than no high school isn't completely understood. But as you get more education, it doesn't protect you. And so if any of you listen to NPR, they had an expose a couple years ago about a Black woman who worked at the CDC in Atlanta and had a maternal death postpartum. She shouldn't have had that happen. When I looked at the case, her physician just ignored what was going on with her. And we had long discussions with my residents, because I teach medical students and residents, and they're like, nobody was listening. But then Serena Williams, who you all know from her tennis, she had a pulmonary embolism after one pregnancy. She was pregnant and had a second baby, and she felt the exact same way. So she went to the nurses station at the hospital and said, I'm having another pulmonary embolus, and nobody listened to her. So those are 2 examples where their education, their social status didn't help them at all. Luckily, somebody finally listened to Serena Williams. then if you look at Hispanics, there's not a lot of change about how much education they have. But it's really striking with Caucasians how you decrease the risk. And yet, what implicit bias do we have? What problems do we have with not listening to Black women when even when they're educated and know how to have a voice, they don't get listened to, is what our concern is. And it's not all been proven, but that's part of the concern of what we're dealing with right now. And these are the leading clinical causes of pregnancy-related mortality up to 1 year post-birth. And it used to be that hemorrhage was number one, infection was number two, and blood clots were number three, and now it's cardiovascular conditions. And how that all relates, we don't really understand. As an OBGYN, I didn't always even have to listen to somebody's heart and lungs when they were pregnant, except for first visit and when they came into labor and delivery. And now I'm listening to their hearts all the time and really trying to figure out what's going on and paying much more attention to what's happening. And then what the problem is varies whether patients die when they're pregnant within 42 days or 43 days to 1 year. So this is where that cardiomyopathy comes in at 43 days to 1 year. And that hasn't even been on the obstetrician gynecologist radar until the last 5 years, much less any of the lay public's radar, that there are these cardiomyopathies. And then here are chances of dying in childbirth and with the different states. And as you'll notice, Kansas was one of the states where there's no information. Missouri is sort of in the middle. You really don't want to be having a baby in Oklahoma, Arkansas, Kentucky, Alabama. But part of this could also be their data collection. So places like New York State that don't look so great probably have I trained in New York State, and they have a pretty robust tracking method. And California is the one state in the union that has decreased their maternal mortality rate. They came up about 10 years ago with a project to look at high-risk pregnancies and high-risk situations and simulations, which I'll talk to about a little bit later. And they have decreased their maternal mortality rate in California. And we're trying to do that now all across the country. So it can be done. So the solutions that we think we might have are integrating multidisciplinary care for women with high-risk comorbidities during preconception care, pregnancy, and postpartum. And all of you've been to the doctor's office and see them poring over the computer while you're trying to get seen and examined, right? And it drives us all nuts, okay? What you don't see that I see on a daily basis is that if I don't click all the little points of where the patient might have been seen in the last year or something, I don't know that she's been seen by cardiology if she doesn't tell me. I don't know that she's been seen by the renal folks. I don't see that she's had 25 psych visits, okay? I have to get in to the computer and go to each of those little icons and figure out what other problems the patient has. And then their history comes forward, but you got to make sure you read the history that comes forward, and is it accurate, or did somebody mistype something in there? So one of my friends says it's springtime, so we all are familiar with Easter egg hunts. Hopefully you guys had some this spring. So my friend says the electronic record is like an Easter egg hunt. You never know what you're going to find when you overturn a rock. And with the paper charts, at least if the patient had been seen at the same facility before, if the patient only told me a little bit, I still had, and I had a chart this thick. I knew I better be looking through the rest of that chart to see what else had been happening that she'd forgotten to tell me about, okay? And I get nervous when I go to the doctor. I'm sure all of you get a little nervous. You're worried, what are they going to tell me this time that I don't know that's going to catch me off guard, you know? And, or we may have a complaint and we're really not feeling very well when we go in. So the electronic record is probably a little bit of a problem. And then you get into silos. So I'm really old fashioned. So if I have a question for the pathologist that's reading a pap smear, I go down and I talk to him and we actually look at it with under the microscope. And if I don't understand a radiology report, I go down to radiology and quiz the radiologist on what's going on. Explain this to me. The younger folks all think that everything's just in the computer. And so trying to delineate exactly what's going on has gotten a little bit more difficult. But so we need to get multidisciplinary teams where you get the cardiologists and the OBGYNs working together for the patients who have heart disease and all that kind of thing. So that we have, and we also need the psychologists and the psychiatrists working with us. We have a psychologist at Truman who her only job is to screen the women who are coming into clinic with help from all of us and getting them into care if they've got anxiety or depression, if they're suicidal, whatever's going on, if they're depressed. And we're unique in the Kansas City area to have somebody who is embedded in our obstetrics clinic. Getting patients to mental health care is really tough. There's an average of 3-month wait to get into to see psychologists or psychiatrists or licensed social workers. And that's in private practice and at Truman, except for when I've got this psychologist who I get people into the same day or the next visit that they're coming in. We need to address structural racism and social determinants of health. When they've surveyed African-American women, they've said that we don't listen to them, we don't listen to their birth plans like we should. And then some of the solutions, one is to implement hospital-wide safety bundles with team training and simulations. And this is what they've done in California. So one of the first things they had was postpartum hemorrhage. And it doesn't happen very often, although it's happening more frequently now with our obesity. And you got to know exactly what to do and exactly what meds, because a patient can lose a liter of blood in about 30 seconds sometimes, okay? And if you don't have a well-oiled machine to know exactly what you're supposed to do and what medicines you're supposed to give, you're up the creek without a paddle. So one of my jobs at Truman is I train the residents. Every year they have to do a shoulder dystocia where the shoulder gets stuck because you get too big a baby and it can't get through, and postpartum hemorrhage and eclampsia. And we do amniotic fluid embolism intermittently and some other drills. So it's great when I do a postpartum hemorrhage around Halloween. I can get the stuff that looks like feet tracking blood across the floor going into the bathroom, okay? And we have fake blood, and we can't afford at Truman an $80,000 mannequin that's like, you know, the ones they use for CPR. Well, the ones that deliver babies are $80,000. They're called Victoria now. So my sister's a home ec teacher. And so we found parto pants. So parto means birth in Spanish. And so we took a pair of extra large scrubs and we put, so all of you who sew, she put places for you to put hands in that aren't usually in scrubs. And we put in an area that feels like the pelvic bone, so a little bit of extra interfacing, okay? She put in pockets so we could have blood in there so that we can, it's fake blood, but that we can have the hemorrhage happen. We can simulate that. And then we simulated the outside of a vagina with swimsuit material, okay? So So we made 2 pairs of these. They're essential to me. They're really neat because I get one of my students or residents or nurses, and we put on our Lululemon pants, you know, or something like that underneath, and then we can interact with the resident and with the nurses, and we make everybody have different jobs. So I may have nurse number 1, nurse number 2, resident number 1, senior resident, attending person, and we make people play different roles, okay? And then we have everybody interact with this person who then we have a baby doll that we deliver through the swimsuit material, okay? And we have them figure out what they need to be doing. It's great. The new interns only look at the ladies' private parts. They don't know that there's a head up there and somebody to talk to. So we teach them how to do that. We teach them how to use the medicines. Sometimes we'll get the nurse to pretend that she knows absolutely nothing. She's brand new. So when they say, I want Pitocin, I want Methergin, I want Hemabate, she goes, I don't know the dose. I don't know how I'm supposed to give it. Or some of the medicines that you only give as a shot intramuscularly, they'll go, I give that IV, right? Well, that would cause real problems. So we see if they can connect all that. So we have these high-risk drills. And it's been shown through the California studies that it decreases the maternal mortality rate. So we do the same thing for seizures. Taking blood pressures. All of you ladies whose legs are crossed have a 5-point increase in your blood pressures if we took it right now, okay? You're all, which is fine when you're sitting here, but not when I'm taking your blood pressure in the office. If you ran in and sat down and you haven't sat there for 5 minutes, your blood pressure is going to be higher. If you sit in a chair without a back in it, my blood pressure is going to be higher because I'm on the piano bench. Your all's blood pressure is going to be lower because you're sitting with your backs against the chair. So learning how to take proper blood pressures for pregnant women so we didn't overdose, diagnose, or underdiagnose preeclampsia and hypertension was another initiative. We actually did that with the anesthesia students at Truman, and the anesthesia student who wrote it up, we came in 4th in the country for the prize for that education piece that they did one year. So they have competitions now for us, and we've applied to 2 of them. And then we need to provide patient education on early warning signs for medical complications of pregnancy, because our patients don't know what to look for. If anybody's had a baby, you may have attended a childbirth class. I didn't know till the last 10 years, and I've been doing OB since 1980, okay? So I'm not calculating the number of years, but I had no idea that childbirth classes did not discuss the warning signs for preeclampsia and eclampsia. And so we've added that in at Truman, but they talk about preeclampsia or eclampsia. Preeclampsia is when you have high blood pressure and protein in your urine, your kidneys aren't working, and the ladies will swell up a lot. And eclampsia is if they actually have a seizure. Right, and that's a problem because it's more common with obesity and then our hypertension that's increasing in the country, and our patients don't even know to look for it. Okay, so we want some warning. Beth, I'm going to put you to work. I have 2 different handouts, and I'll show you slides of them here in a second. And I actually would love to have your opinions on them as lay people if they make sense. So the A1, which is the Nurses Association for OB nurses, looked at Save Your Life getting care for post-birth warning signs. So they made it like a green light, red light, when to call 911, when to call your healthcare provider, what to say when you call. And we're trying to hand this out to everybody before they go home. Because a big problem is that patients don't even know, if they don't know that they're supposed to come in for a postpartum visit, they also don't know when to call. And then this one came out first. And then the second one that came out is urgent maternal warning signs. And this is from if you can read this at the very bottom, it's a council. Do you have one of those can somebody read the bottom little teal and purple thing?
Council on Patient Safety and Women's Healthcare.
Yeah, so that's where our simulations are coming from that I'm talking to you about, and they're using the California data, okay? And that's where we came in 4th place on one of their nationwide challenges, and we're still waiting to hear where we came in for psychology. I like the urgent maternal warning signs, the second one, except that vaginal bleeding or fluid leaking after pregnancy, well, everybody who's usually has some bleeding for up to 6 weeks postpartum that can be normal. So I wish they said that it was heavy bleeding after pregnancy. But otherwise, I don't have a whole lot of problems with either one of these. The idea is that we need to be telling patients about them. So the preeclampsia, the things that you have there is a headache that doesn't go away with Tylenol. The changes in their vision, they'll get black spots called scotomata. And they'll get severe belly pain in their right upper quadrant, which is the liver swelling, which is all things that happen with preeclampsia. Yeah.
Am I correct? And it's also dangerous for the baby, correct?
It's all, yeah.
Doesn't it produce possibly miscarriage?
Yeah, fetal death and yeah, it compromises the baby because there isn't adequate blood flow to the baby, right? Yeah, so it's not only maternal, but it's also fetal issues, yeah. We're trying to figure this out and how to get this information out to people. So if you all are looking for something to do after this lecture that might impact, that wouldn't cost a bucket load of money, it would be coming up with unique ways to get these warning signs out to people, because it's not done in the private doctor's offices nearly as well as it should be in Johnson County, most likely, although I'm now 10 years down at Truman. I practiced 11 years out in Johnson County. Hopefully the hospitals are all using it. But getting this into patients' hands early, and even before pregnancy, if there's some place that women are coming in and they've got some downtime and you want to educate them, getting them things like this would be one thing that I was thinking about that might really help. And then we're trying to regionalize maternal levels of care. So you all know that there are trauma centers, like Overland Park Regional is a level 1 trauma center. Truman is a level 1 trauma center downtown, not out at Lakewood. St. Luke's, I think, is on the plaza, is a level 1 trauma center, but not out in Johnson County or Lee Summit. So we have places that have special care. So we always have a surgeon on call at Truman so that whatever trauma comes in, there's a whole team that's ready to take care of them, and they have to be available and they get certified. And so in the nurseries, they've had that. So the highest level nursery is Children's Mercy because they do fetal surgery there. Overland Park Regional has a little bit of that now. They're also a level 4 nursery. Menorah Medical Center is at a lower level. They can take care of patients, babies who are sick and who are past about 32 weeks and might need a ventilator for a short period of time. But if they're real sick, they're going to get transferred to Overland Park Regional, okay? St. Joe doesn't have a nursery. St. Luke's South is going to be the same level nursery that Menorah is, okay? St. Luke's East is going to be the same level as Menorah. St. Luke's on the Plaza is one level higher, but they don't do fetal surgery or neonatal surgery, so they send everybody down to Children's. So we've done this for trauma, and we've done it for the nursery, and so now they're looking at doing this for OBGYN. So it's really hard when we're on a state line, okay, and trying to get regionalization of medical care, and everybody's got to compete with each other. So I don't know if it will ever really happen here, but I can tell you in New York City, where they've been doing regionalized medicine for years and years and years, Columbia University is a place where if you have a abnormal placenta that's a previa that's low lying and then it's grown into the bladder, that's called an accreta, and those patients can lose buckets and buckets and buckets of blood. The hospitals in New York City transferred the patients with a known accreta to Columbia because they've got a team there that's prepped and ready to go. And so they have better outcomes for the moms. So that's one of the things that we're looking at here. That
it grows into the bladder?
Yeah.
I thought it was stuck to the lining of the uterus.
That's what it's supposed to do. But if you've had multiple C-sections, is our new risk factor, and our C-section rate is higher. If you get that placenta right over that C-section scar, it can go through the uterus and into the bladder. And you can imagine that that's a mess. Okay, so I hope that wasn't too technical. I'm sorry I said eclampsia a couple times, but hopefully it was the idea that maternal mortality is an issue in the United States. We're the only first world country where it's increasing. And leave it open to some questions and anything else about perinatal care. I am just a general OBGYN doctor. I am not a maternal fetal medicine specialist, but I'll still can answer questions. Yeah.
Perhaps put this on neighborhood.com. They're always advertising nonprofit things like collection for homeless people. They'll say, bring your sleeping bags or towels to my front porch or whatever. So this should fit in a little advertisement on neighborhood.com.
Awesome. Okay. Yeah.
I read, I think last year, something in the Kansas City paper, some paper, I'm not sure which one it was, and it had an article about how women were being encouraged to check the heart rate of the baby, and it was like every 10 minutes, for an hour or something, and then every day, something like that. So
actually, it's kick counts.
Yeah.
Because it's alliteration, okay, although it should be called movement counts. And it's where we encourage the moms to lay on their left or right side unless they have a baby that they can really feel easily, twice a day. Some people say just once a day. And you count how many minutes it takes the baby to kick 10 times. And if the baby kicks at least 10 times in 2 hours, then the baby's usually okay. So I'm a believer in kick counts because I think aside from cord accidents that we can't predict and abruptions where the placenta comes apart. So if you get a knot in the cord, we can't predict that. And if the placenta comes apart, like due to high blood pressure or cocaine use used to be one of the things. So any of the drug use, amphetamines and stuff could cause an abruption. That we can't predict because that just happens all at once. But if you've got the placenta not working because of diabetes or because of chronic hypertension or some other problem, the babies frequently slow down about 12 to 24 hours before they die. So the studies that are the most optimistic for kick counts are that it cuts the stillbirth rate by 50%. Some studies show it doesn't do a darn thing. The thing is, it's cheap, it's easy, you do it at home. I tease my patients, you're not waiting in the office for me. But at best, it cuts the stillbirth rate by 50%. At worst, it does nothing. We get very few patients that actually make a trip into the hospital because their kick counts are lower. And for a lot of our patients where pregnancy wasn't intended, it helps with bonding. So, you know, if you're feeling that baby move and you're paying attention before the baby even comes out, and learning the baby's biorhythms, because the babies have biorhythms just like we do. So we tell them to always try it when they know the baby's usually active. So kick counts may be helpful, they may not be, but yeah, I'm a believer. So you can do it, there are a gazillion different ways to do it if you look on the internet. I do the quick and dirty because I know my patients are busy. So I have them just count how many minutes it takes the baby to kick 10 times. And over 98% of my patients, they're done within 5 to 20 minutes. So if they don't get 10 kicks in 2 hours, I tell them to make sure they're calling. But realistically, it's much shorter time. Now, babies have 20 to 40 minute sleep-wake cycles. So if the baby's not moving at all when they first start, and they're used to the baby moving in 5 minutes, I'll say, you know, remember the sleep-wake cycle, your baby may be sleeping. And then you get out pots and pans and bang them together, and it wakes the baby up. And I tease them, if they start at 10 o'clock at night when the 10 o'clock news comes on, and I swear that jingle wakes up most of the babies, but if that hasn't woken them up, then get the pots and pans out. And I really don't care if they wake up all their neighbors and all the other children in the house, okay? We used to use the vibrating things that folks who have had throat cancer and the artificial larynx, we used to use those. Those are hard to find. We wanted to figure out if you put your cell phone on loud and on vibrate, would it work? And the cell phone companies won't let us do it because they don't want the liability. So we're back to pots and pans. So, and Truman is a private hospital, but it gets a lot of funding from the Jackson County, and we have a lot of Medicaid patients, and we didn't have a lot of money back in the 90s when I was there. And we had a woman who did non-stress tests where you get hooked up to the monitor and the baby should kick twice in 20 minutes and the heart rate go up 15 beats for 15 seconds. And we know the baby's good for another week inside. And so we do this for high-risk pregnancies. And Mrs. Jones just died last month, but Mrs. Jones had her pot and her pan and her wooden spoon, and she banged them. And so we always knew, the entire clinic knew when she had a mom whose baby was not passing its non-stress test, because we all woke up.
Is that Carolyn Jones?
It's Carolyn Jones. Yes.
I saw her the other day.
Yeah, she just passed recently. Yeah, yeah. So she was one of a kind. So she was a woman who worked at Truman for a long time and deeply cared about her patients. So.
And before me, I was there in 68.
And she was there before that?
71. I was there 71.
Yeah.
She was there long before that.
Yeah, yeah. So.
Well, I have a question about cardiomyopathy.
Yeah.
Is that, do you break that down according to rates, incidence according to rates in your statistics, or do we just say cardiomyopathy is one of the?
We know historically that it was more common in our African Americans than in other folks, but now I don't have the statistics recently where we've seen this huge increase. Part of the increase now is the babies who have congenital heart disease like tetralogy of Fallot, and they've had their surgeries as an infant. So they grow up and they look fine and they do everything fine, but they have a baby and that pushes their heart over the edge. So we're finding cardiomyopathy in folks with congenital heart disease. And I don't have a breakdown of the numbers with that now and how obesity and hypertension are relating to that. So we don't know. So historically, we always worried about it in African Americans, but it's now across the board that we're seeing more of it. So we don't understand it at all yet.
I was just thinking, we didn't have coke and meth, and when I
Right.
started nursing, we had heroin and marijuana, and most of the time our mothers were not heroin addicts, even if they were in the inner city.
Yeah.
And we didn't have a lot of prescriptions, we didn't have opioids, we didn't have depression pills,
Yeah.
And I was just wondering if the increase in that is correlated to the increase in more cardiomyopathy.
We don't know yet. So those are the exact questions that we're asking. Okay. So, and Kansas doesn't have a maternal morbidity mortality review. They just instituted one in Missouri, and they're looking up till a year post delivery, and they're finding a lot of suicides and drug overdoses as part of their issue. And, you know, when you get the economy, can you imagine not having any money, not having a job, and having a new baby and all the stresses that gives? So they're looking at some of that.
What year did you say the mortality rate began to go up again?
Let me go back. It's 2003, they changed the reporting. So I know it started going up by then, but it was actually the late 1990s that it started going up again.
Apparently just recently, Alma Adams, Lauren Underwood, and Cory Booker have passed are trying to pass the Black Maternal Health Omnibus Act because of the high 3 to 4 times more likely Black women die from maternal pregnancy complications. So I don't know if it would help people, but their senators to encourage that act to pass the road.
So, yeah.
Call it the Omnibus Act. That's awesome.
Yeah, yeah. And the only state that has maternal mental health coverage for the patients in the entire United States is California. And Illinois just passed a law last week to try to get that to happen, that they'll have it. If any of you have ever had yourself or any family members going through psychology counseling, you know, you gotta wait to get the appointment, you gotta get the appointment, you gotta meet somebody, you gotta decide that the person that you're meeting with is a good fit or a bad fit, you gotta get some trust. And for all the Medicaid patients across the country, except for California, now maybe Illinois, all of the benefits, if you're on Medicaid, are cut off at 60 days. So that's a big issue with the mental health. So
60 days worth of
maternal Medicaid, and then it's gone. And 43% of all births in the United States were covered by Medicaid in 2016.
40%.
43%, yeah, are covered by Medicaid. So that means most of the women, and Kansas and Missouri have not expanded their Medicaid. Missouri's supposed to be expanded, but now there's the funding issue in the state of Missouri, but Kansas hasn't expanded their Medicaid. So if you're indigent, unless you're really, really, really rock bottom, and I can't quote you the numbers for that, you get care for the mom for just 60 days after they deliver, and then it's gone. So, I mean, that's the other push we have. You know, the only time a lot of my patients who have Medicaid can ever get dental care is when they're pregnant. So we have a whole sheet, and we know which places on the Missouri side will see our patients who need dental care who aren't scared of pregnant ladies. Because a lot of folks in other specialties are, you know, oh my goodness, can I really take care of them? And yes, now we know if moms have bad periodontal disease, so they got rotten teeth and gums, they are at higher risk for a preterm delivery, but we actually have to treat them before they're pregnant. If we treat them when they're pregnant, because that study could be done, because we could get the patients treated, because they had insurance, we found that it didn't decrease their preterm delivery rate. So, and then think with COVID this last year, how many people didn't go into the dentist and where we're at with that.
You say 45% Medicaid in 2016?
2016, yeah, I don't know the numbers right now.
You think they're dropping, right?
I think they're,
More Medicaid?
I think with the unemployment from the last year, it's going to be rising. It should be have risen this last year. When we had more people employed, if they were well employed, so that they were making enough money to qualify. But, you know, if you look at a lot of the low paying jobs that women qualify that don't have a lot of education, they don't qualify for insurance. And then a lot of the big companies do everything they can to give you 29 hours, but not 30 hours of work, so you won't get benefits. I try to target which big box stores I'll go to. I have a friend who lives in Olathe who keeps up on who keeps most of their employees below a level of work so that they'll get health insurance, and which ones actually give health insurance. And I haven't seen him because of COVID now, but he would tell me which big box stores to shop in and which ones not to shop in, because he had a little more time to look at it than I did. But yeah, and a lot of employers do that, not just big box, but all across the board. They do that to avoid paying those benefits. So yeah, so it's a big issue.
Some of the things we can do would be to tell young marrieds to talk about pregnancy with OB/GYNs before they have babies.
Oh, really? Yes.
While they're having babies, and to go back afterward.
Yep.
And to be connected with moms who have resources that might be able to share. Is there anything that you think we should do proactively on an even younger level in the high schools, or ways that we could maybe speak the truth before it's too late?
I know. It's really hard to figure out when they're key learning moments. So we know that there's so many folks that don't go on to secondary education, so that we need to get folks when they're in high school and younger. I grappled for years. I have some patients who are very involved in Hadassah, which is a Jewish women's group for education, sort of like our circles that we have. And they gave money and would go out into the high schools to discuss breast cancer screening and testicular cancer screening. Well, testicular cancer screening was good for the guys because that happens in their 20s, so they might remember it. The breast cancer screening, looking at breast cancer that happens at a much later age, when you start mammograms and stuff, was sort of worthless to high school students. So I applauded them for trying to do something, but I was like, maybe their time would have been better spent with discussing prenatal care or preconception care. So trying to figure out with folks when that key learning moment is, I don't know the right answer. We've got adolescent medicine folks at Children's who could probably tell us when the time is. My sister's a food and consumer science teacher in New York State, and it's a required course. And part of what she teaches is how to make a budget, what different fruits are and stuff like that. I mean, it's really pretty fascinating what she does. But they moved it, even though it's still a required course, they moved it from 7th and 8th grade down to 6th and 7th grade. And 6th graders don't want to listen about keeping a budget. And then she said the horrifying thing is, for her cooking part and her sewing part, she goes, sharp needles on sewing machines and knives with 6th graders. Is that like totally nuts? So, you know, I know that, and she had to teach health this last year because of COVID. And she's like, they don't want to hear a darn thing I'm saying. They're still at figuring out menstrual cycles and stuff, much less periconception stuff. Or preconception stuff. So I don't know the right age, but I think that's the question to ask. Absolutely. Yeah.
I have granddaughters 38, her husband is 45, and they're expecting their second baby in September. Do you see many patients in this age group that are having their babies?
Do I see what in that group?
Patients.
Do I see patients? Oh, yeah. Oh, yeah. Lots of patients in their late 30s and early 40s. And if you've had one baby before and you're less than 40, you usually do pretty well because you don't have any underlying disease that's been uncovered. The women who are past 40, that's where you have the obesity, the hypertension, the cardiac disease, and a pregnancy uncovers it. So my first time moms, 40 and above, those are the ones I really worry about.
Well, of course, you have no OB/GYN, and she also
Right.
has a high risk, what would you call it, high risk birth.
Yeah, yeah, maternal fetal medicine. Yeah, and they're watching her for something. Yeah, and so that should be great. That's exactly what she wants, is to get all those specialists.
And she goes back for blood work and
Yeah, the maternal fetal medicine or high-risk pregnancy specialists, they try to consult, and they do a lot of ultrasounds and they consult on the high-risk pregnancies, but they don't do the deliveries as much anymore. It's sort of changed over the last 15 years. Okay.
And I just
Oh, I'm sorry, I went too long, way over, I'm so sorry.
typed in the chat to see if our online friends had any questions, and I don't see any at this time.
Okay, great.
I think,
on the Zoom?
yes.
I mean,
I'm sorry.
is anybody new that's not?
Well, I don't know. I don't have that screen open right now. I can look. So if there aren't any more questions, thank you.
Stop.
so
Thanks.
much, Dr. Hall. And Dr. Mo, you had mentioned, I just remembered this though, that there might be something else that we could do besides, do you want an opinion on this? And
So I wanted to, yeah, sort of an opinion, do you like one better than the other, or do you like both? Getting that word out. And then, yeah, we're remodeling at Truman, and they're putting in a new NICU. So all the parents will be able to have a bed right next to their baby, just like, which is even going to be fancier than children's, and new labor and delivery. And so if there was something else that you all wanted to do, I can get you to the right people down there. If anybody's driven downtown lately, there's a big new research tower at Children's that the Sunderland family has donated, and they have donated most of the money, if not all of it, for the intensive care nursery that we're going to have at Truman, because our nursery was donated by the Hall family back in the 90s, and the bassinets are on top of each other, the incubators, and it doesn't meet any code anymore, but it was state of the art in the 90s when the Hall family helped donate. So, once COVID's over, if somebody wanted to come down and do something at Truman, and once we can let volunteers back in, you might want to do something with that, because we certainly have lots of unmet needs. So, yeah, so it doesn't have to be monetary, it could be in-kind sort of stuff. So,
keep those ideas in mind. Yeah, I was gonna say, I especially like I think the one, not that one, but the other one.
Why do I?
that one, It's just, it intrigues, it makes you want to kind of look and see what those things are, and,
I think especially because some of those are common, so you wouldn't think about it maybe as possibly being a problem.
yeah, okay, good.
Do 911 operators get things like this?
I have no idea.
Good question.
It's a great question. So I know the nurse lines at the hospitals, like Shawnee Mission has a really extensive nurse line. I'm sure they've got information like that for when to call in. So our residents answer most of the questions at Truman.
I can see just even knowing that that could be a problem, you know, you might be feeling that, but not know that that could be.
I had no idea that we had increased maternal mortality.
Yeah,
Increasing.
and increasing, yeah. That's why Beth asked me to talk, was because it's a big deal.
A couple years ago at Lydia Circle, and then we thought this was really.
Thank you, Dr. Winter.
Oh, you're welcome. You're
helpful
welcome.
information.